All right, we're going to go over a quick presentation on T waves. If anybody knows who this gentleman is, on the screen, this is Rodney Dangerfield, and I like to refer to the T wave as the Rodney Dangerfield of the ECG. So why are the T waves the Rodney Dangerfield of the ECG? Well, Rodney Dangerfield was a comedian, for those who don't know, and one of his sayings was, "I get no respect." And I like to think of the T wave as Rodney Dangerfield. It doesn't get a lot of respect. We tend to put a lot of emphasis on ST segment elevation, ST segment depression, and we often ignore the T wave. But as you'll find in this presentation, the T wave can give us lots of valuable information. All right, so the T wave comes in two flavors, so to speak, either inverted or tall. What I like to refer to as the big ass T wave. So inverted and tall. So let's talk about inverted T waves first. So there's lots of different reasons that the T wave could be inverted. It could be cardiac ischemia, right? So if you see inverted T waves in what we call a coronary distribution, so inverted T waves in 2, 3, and AVF, or inverted T waves in V3 and V4, or inverted T waves in V5 and V6, right? These are in very specific anatomical leads that look at a very specific area of the heart. And this could indicate that the heart is ischemic, right? We're not going to activate the cath lab on inverted T waves, but we're going to sit up and pay attention. This is a red flag that something is awry, and we're going to get serial EKGs. Pulmonary embolism, another reason the T wave can be inverted. In pulmonary embolism, you'll often see inverted T waves in your inferior leads, so 2, 3, and AVF, along with your right precordial leads, so leads V1 through V3. And this just indicates a high right atrial pressures that are very common with PE. Now, many of us in school, we learned about the infamous S1Q3T3 pattern, but this is very, very, it has a very poor sensitivity for pulmonary embolism. In fact, less than 10% of pulmonary embolisms will have the S1Q3T3 pattern. Whereas T-wave inversion, almost 50% of patients with a pulmonary embolism will have this finding. Pediatrics, so pediatric patients, it may be completely normal to have inverted T waves, particularly children under the age of 8. That's normal. It's completely normal. So when you do that EKG on that 6-year-old, and you see inverted T waves, they're mainly in the right precordial leads, so V1 through V3, you would expect to see inverted T waves. Left ventricular hypertrophy with strain pattern, very, very notorious for having inverted T waves in many leads. Bundle branch blocks, we've all seen bundle branch blocks. They can have inverted T waves. Wellens or Wellens syndrome is very common. You'll have inverted T waves. What Wellens is, it was named after Dr. Wellens. And what Wellens is a reperfusion syndrome. So you have someone, they're having chest pain, they have an occlusion in the coronary vessel. The occlusion spontaneously resolves or spontaneously reperfuses on its own. And what was ST segment elevation now becomes T wave inversion. So the history that you would get is a patient that was having chest pain, is no longer having chest pain anymore. You get a 12-lead ECG and you see inverted T waves in V1, V2, V3, and sometimes V4. This is not a good sign. These patients need to go to the cath lab. They have a very, very high percentage of re-occluding the vessel. So when you hear that history, I was having chest pain, I'm not anymore, and you see these inverted T waves. And I'm going to show illustrations of all these ECG findings here in a moment. Increased intracranial pressure does have the potential to give what we call these deep cerebral T waves. Persistent juvenile T wave syndrome. So this is more prevalent in young women, teenage women up into their 20s. They can have these inverted T waves. They're typically small, and they're usually isolated to V1 through V3. You should never have, never, ever, ever, ever have inverted T waves in your lateral leads. That would be an indication that there's some sort of ischemia going on. And then your different cardiomyopathies. So you've got hypertrophic obstructive cardiomyopathy, and you've got dilated cardiomyopathy, and you've got arrhythmogenic right ventricular cardiomyopathy. So you have all these different cardiomyopathies, and we're not going to go into depth into these. That's a lecture all on its own. But I just want you to keep that in your mind on the syncope patient. You obtain an EKG, which you should because it's syncope, and you see these inverted T waves. It could be a cardiomyopathy. So let's look at some examples. This is an 8-year-old. You see that T wave inversion in V1, V2, and V3. And this is completely normal. This is normal for a child. It indicates those high right atrial pressures that the child had in utero. And as they age, this should slowly transition to upward T waves, at least by age 10 to 12. Here's an example of that persistent juvenile T wave syndrome. So think young women. It's typically isolated to V1, V2, and V3, and they're very symmetrically inverted T waves. Here are T waves of an ischemic nature, right? So we have some sort of occlusion in the vessel, the heart's angry, and we see it in an anatomical, a coronary anatomical distribution, right? So 2, 3 in AVF, or over here in our lateral leads, 1 and AVL. So those are cardiac ischemia T waves. Here are the inverted T waves of pulmonary embolism I mentioned. So you've got inverted T waves in lead 3, AVF, lead 2, and then V1, V2, V3. So once again, history super important. Maybe this patient's having shortness of breath. They're having pleuritic chest pain, and they have risk factors for PE. They just got off a 6-hour plane ride, or they've had a surgery or been immobilized for a long period of time. And now you get this 12 lead, and this is what you see. Bells should be going off in your head. Pulmonary embolism. Here's the T waves of cardiomyopathy. You see diffuse T wave inversions, and you see those big QRS voltages reflecting the thickened heart muscle, the thickened myocardium. Here are those T waves of intracranial pressure. So this patient had a head injury. And the thing to note about these T waves is they're very, very deep, symmetrical T waves. Very, very deep. And once again, history is super important. This isn't going to be your elderly patient with chest pain, right? This may be the elderly patient on anticoagulants who fell 2 days ago, and now they're presenting with altered mental status, and you're thinking maybe they have a head bleed. Here are the T waves of Wellens syndrome, right? V2 and V3. Now there's 2 types of Wellens. There's a Wellens A and a Wellens B. The illustration on the left is Wellens A. So you have this up-down pattern of T wave inversion, whereas Wellens B will have these symmetrically inverted T waves. And they're usually isolated to V2, V3, and V4. All right, those are T wave inversions. Let's talk about the big, tall T waves. And they come in two flavors. So we have the big, tall T waves of coronary occlusion, right? When you see the T wave and it towers over the QRS, I want you to get a little worried. I want you to do serial EKGs, and I want you to be concerned about occlusion. The T wave should never be larger than the QRS. Here's another example. These are actually called De Winter's T waves. So you have a little bit of ST segment depression, and then it slopes into this tall, symmetrical T wave. V2, V3, V4. I want you to think occlusion. If you look over here too in lead 2 and lead 1, you have some depression as well. Here is a sign. This could be confused for hyperkalemia, right? Because we all learn tall peaked T waves of hyper K. But you see this has depression and it goes into a tall T wave. Think occlusion. Once again, big, fat, wide-base T waves, taller than the QRS. This patient had a 100% LAD occlusion. Now let's talk about hyper K or high potassium. Look at the difference between these T waves and the T waves of occlusion. These T waves are dagger-like. They're sharp, pointy. I mean, it looks like if you sat on them, they would skewer you, right? Hyperkalemic T waves are tall and pointed. And we're going to think about history as well. So you would expect to see hyperkalemia in the patient that's acidotic, the patient who has end-stage renal failure, things like that. They've missed dialysis for the past week. You have to take the EKG in conjunction with the clinical situation. So once again, two types of T waves. You have T wave inversion and you have big, tall T waves. Thanks a lot.